तो बहुत डिस्टर्ब कर रहा है. गुड इवनिंग. गुड इवनिंग. तो बहुत डिस्टर्ब कर रहा है. गुड इवनिंग. ये देर से आ रहा काफी मतलब. क्या किया जाए. Good evening to all of you. From today onwards, we are starting a Facebook Live, especially on tuberculosis. And in this series, we will have many more lectures related to tuberculosis. But today, what I will be focusing on, drug-resistant, drug-sensitive pulmonary tuberculosis. I always this is KDMU from 42 years here that I became director of this Institute of Medical Sciences, SAFI, and then finally I went to Patel Test as a director. Currently, I am working in Era Medical College. What I will do in next half an hour, what is update in diagnosis of especially the drug susceptible TB, update on treatment of drug susceptible TB, and maybe a minute in the end I will be talking on what is the future of TB treatment, especially in drug susceptible tuberculosis. You see this X-ray, you will agree with me that there are bilateral extensive disease. This man was proven as tuberculosis sputum positive way back in 2004, and then he was given 6 months of ATT. Patient has responded clinically, radiologically, and sputum wise also. And you know that treatment was stopped after 6 months because that was the treatment duration at that time. And then we are following this patient, he is still alive, and you know the lesions are vanishing even without treatment. What I am trying to say, don't try to treat radiology, treat patient as a whole. Then you see this is another patient where you find there is a cavity. There is a cavity in the left lung which ultimately healed and disappeared under good treatment. So, what I am trying to say that tuberculosis is 100% curable disease to me if the good prescription are given and patient takes those prescription. But it is very unfortunate that more than 25% of the cases globally are in India. There are 15 lakhs death last year with tuberculosis globally. In India also around 5 lakh people died, and the time I will spend with you maybe 20 to 25 people will die with tuberculosis. Is it not a paradox? Yes, it is a paradox. Why? To examine this, if you see that patients of tuberculosis, where they go for treatment? They go in private sector, they go in the government sector, sometimes they cross each other. Let us examine TB management in the public sector, in the government. You know, we have a lot of political commitment. You know, our Prime Minister addressing the end TB strategy in 2018, where he declared that the TB should end from India 5 years earlier than as envisaged by WHO, that is 2030. So, by 2025 this is a vision, and in the and to prove that vision, there are lots of updates has been there. You know, in 2019 before COVID, out of 26 lakh 24,000 patients were diagnosed and treated. In 21 there was little setback because of the COVID, but still around 21 lakh patients were treated. As far as private sector is concerned, where I believe half of the patient they go for their, I would like to focus one or two slides. In one of the study we did in way back in 2003, and it was published in International Union Against TB and Lung Disease journal. We have audited around 500 patients, doctors who were treating tuberculosis, and we could find that 33 different regimens prescribed by more than 400 doctors. And what was the worst part in that study? That 75% of the doctor made one or another prescription error. Quality of tuberculosis care in India, this was one of the systemic review done in 2015, and that also talks that the quality of care in especially in the private sector is suboptimal. So, what I am trying to say, so you must have understood by now why people are dying with tuberculosis. It is because of the poor quality care of all existing TB patient, may it be sensitive, may it be resistant. Let us spend about 5-7 minutes on diagnosis. How TB is diagnosed today? You know, there has been little change in the nomenclature. What we used to say TB suspect, now it has been changed to presumptive TB. Otherwise, now we have we have two types of TB today. In our OPD prescription, we should write whether it is microbiologically proven, whether it is clinically diagnosed. When I say microbiologically proven, it means where TB is proven either by bacteriology, that is sputum, smear, culture, or by molecular biology like gene expert LPA today. The rest of the diagnosis what we do in tuberculosis is known as clinically diagnosed tuberculosis. Then another change in nomenclature, what you used to call it as relapse, now that has been changed to recurrent TB, otherwise rest of the thing remain the same, and there is clear cut definition when you should presume that person may have tuberculosis. That is very important. Presumptive TB means especially pulmonary TB is the most common. So, cough, hemoptysis, fever, significant weight loss, and any pulmonary abnormality in chest air. If we find that they are known as presumptive pulmonary TB. Likewise, there is definition of extrapulmonary TB also presumptive, and diagnosis is mainly done by, there are various methods of diagnosing tuberculosis. As you said, tuberculin test, Mantoux test, which is a very popular test, but it just detects infection. It cannot tell, even IGRA, it just prevent the infection. And then bacteriology is no doubt today is a gold standard. And when I say gold standard means smear, culture, they are gold standard. Radiology also it is a very sensitive test, but its specificity is not good. And there are other tests like antibodies test, they are abundant, histopathology sometimes you do cytology, molecular biological, lot of new tests like gene expert and LPA has come, which gives you quick diagnosis, very early diagnosis, and even early diagnosis of drug resistance. Today my topic is not drug resistance. So, when I will talk about drug resistance in future, then we will deal with it. Sometimes we require bronchoscopy to take sputum samples, bronchial aspirate, and this is how TB is diagnosed. In radiology, as I said, it is a very sensitive method, but it is less specific, and usual finding. So, the radiology can suggest, it cannot confirm the diagnosis of tuberculosis. And you see this, the X-ray in front of you focus as a bilateral disease having cavity on the left side. It means this is bilateral pulmonary tuberculosis. This is a patient who had fever, there was a miliary shadows. These are the common presentation of tuberculosis in X-rays. This is the lymph node, hilar lymph node, tubercular. This is a mediastinal lymph node, which can be tubercular. This is a pleural effusion, which is one of the common diagnoses in tuberculosis. This is a bilateral pleural effusion, although bilateral pleural effusion has many differential diagnoses, but TB could be one of them. Then we have hydropneumothorax. This could be also tubercular. Another point what I always emphasize while you see the X-ray, there are a lot of healed lesion in tuberculosis. Like here in this X-ray you see, there are multiple calcified lesion. When you took the history, she has already received enough treatment in past. She presented to us with hemoptysis, but since sputum was negative at that time, so he was just prescribed supportive treatment for hemoptysis, no anti-TB drug. So, there are few examples of healed. This is whole of the destroyed lung, it is healed, it will not change with any amount of treatment. Then this is even cavity may persist, what we call it as open negative syndrome, and that may persist, but this is a healed cavity. I have seen many people misusing anti-TB drugs in such type of healed tuberculosis. This is again example of a bilateral thin walled cavities, healed tuberculosis. Bacteriology, no doubt I said sputum is very important. Smear we do two times or three times sputum smear, and it is said very clearly that microscopy is more objective and reliable than X-ray. X-ray, if you just your diagnosis is based on X-ray, there are chances of overdiagnosis, and then sometimes suppose there is lymph node, you do FNSC, that is cytology or histology, you take help in diagnosis. And another question is always asked, do you still treat tuberculosis empirically? Yes, many occasions. That is an example of a clinically diagnosed. When we see that TB is very high, although it is not proven bacteriologically or molecular biologically, then still we believe if it is tuberculosis, yes, we may give treatment, and if he improves, it means diagnosis is proved and you have to complete the therapy. You know, with all the investigative gadgets what we have today, smear, culture, gene expert, molecular biology, the diagnostic algorithm has been changed recently. And there are few more tests which are done, like line probe assays. First line probe assays, they first diagnose tuberculosis, and then they also diagnose drug resistance. Today my topic is not drug resistance. And then gene expert also, it gives you diagnosis of tuberculosis, and it also gives you rifampicin resistance, and it gives within 90 minutes. Technically in a lab wise it takes just 90 minutes, but in a control program it takes 3 to 5 days time, but it is very quick test which can diagnose tuberculosis and which can also diagnose rifampicin resistance. As I said, first line I will talk in next time when we talk about drug resistance in detail about first line and second line LPA. Gene expert, a CB-NAT, a TrueNAT, many type of tests are available. They give you TB and they give you rifampicin resistance also. Gene expert is also known to be very helpful in extrapulmonary tuberculosis like fluid, like CSF, like lymph nodes, many things they can help in the diagnosis. But what I am trying to say, I am warning you, you know, this is a cavity in the right upper zone with fluid level, but this is not everything is cavity is not tuberculosis. You have to be careful. This was treated with antibiotics, so it was a pyogenic infection treated with antibiotics. This is another patient I still remember when he was given anti-TB drug because of the hemoptysis, and when he took 6 months of anti-TB, his lesions has progressed, and somebody diagnose him as an MDR TB, and then I happens to see this patient and investigated with all forms of, eosinophil count is very high. Skin prick test against Aspergillus was positive. Total Ig and IgG against Aspergillus fumigatus were also positive, and this is a skin prick test type 1 and type 3, and this is a central bronchitis. So, all this case have been proven as allergic bronchopulmonary aspergillosis, and when he was treated he become well. So, that is about some time about the diagnosis. So, diagnosis, what I am trying to say, is very important. You have to be firm in your diagnosis. Then next 5-7 minutes I will be dealing with you about tuberculosis. I will taking you from historical background little bit, and basic principles I always says must be adhered. When there was no treatment for tuberculosis before 50s, seat anchor of treatment was good olden days, was when there was no treatment, and but in post, role of bed rest, role of nutritious diet, it was a main treatment before, but now it has got some role to play, but main role as you see. But still some of the patients may require hospitalization, especially associated with emergencies like hemoptysis, pneumothorax, carpal nail, tuberculosis associated with empyema, diagnostic dilemmas and difficult resistance. They still require hospitalization. And what I am trying to say today, what is the most important to have a good outcome of treatment is to adequate chemotherapy and its regular intake. Rest, accommodation, diet, even extent of disease. You have seen in the first case, he has bilateral extensive disease. If you treat adequately, only important thing is the adequate treatment. When we treat, what is our aim? We aim cure the patient, every patient, prevent complications and death, avoid relapses. If you treat fully, it will avoid relapse, reduce transmission potential to susceptible individual, and it will also limit the emergence and the spread of drug resistant tuberculosis. A good treatment aims at this, and usually today we do not prescribe any single drug to any patients of tuberculosis. Usually 2, 3, 4 drugs are prescribed, and drugs are available in a separate kit, separate form, and in FDC fixed dose combination. Choice today in all the guidelines are saying it should be FDCs, because it is simply to prescribe as FDCs, and but only drawback of FDCs, that major drawback is a quality of FDCs. Not all companies FDCs are of good quality. So, whenever you prescribe fixed dose combination, which is choice today, but you should see that should the track record and good quality drugs must be prescribed. Another basic aim, means is the standard. In standard of TB care, which started from 2006, and in India it was in 2014 revised, and that standard, one standard is always there when you treat tuberculosis, that any practitioner treating a patient of TB is assuming an important public health responsibility. To fulfill this responsibility, the practitioner must not only prescribe, that is very important, an appropriate regimen, but also be capable of assessing the adherence of the patient with the regimen and addressing adherence when it occurs. So, please see that whenever whosoever you are treating, every one of you are supposed to, that your patient should complete the therapy. That is one of the standards while you treat tuberculosis. TB notification is another standard, which is now very rule in India. whenever you diagnose or treat tuberculosis, it should be notified. Doses, usual doses of drug sensitive tuberculosis or drug susceptible tuberculosis, most of you have to know the doses, because you have to prescribe the if you are prescribing a separate drugs, then you have to prescribe according to weight. What I have seen, person is 60 kg and person is and doctors are prescribing rifampicin 450. This is a wrong practice. As you see here, the dose of rifampicin is minimum 10 milligram per kg body weight. So, anyhow the more than 50 kg, we have always taught that rifampicin dose should go to 600. And usually the duration of treatment is 1 to 2 years in conventional. What is now nobody gives conventional treatment, but short course chemotherapy is usually 6 months standard. But sometimes when short course chemotherapy, when these drugs are not tolerated, you ultimately go to the conventional regimen like INH and ethambutol, then the treatment has to be extended. And that is why I have made one slide and to talk to you that what should be the duration of treatment. In duration of treatment, if you have used pyrazinamide in intensive phase, then treatment is of 6 months. If anyhow you have not used pyrazinamide in intensive phase, only went up to ethambutol, then treatment duration must not be less than 9 months. And if you have not used rifampicin and pyrazinamide both, then treatment should go for 1 to 2 years. That is what is basic principle, how we decide the duration of the treatment. Monitoring is usually done when you treat your patients. Monitoring is done as bacteriology is the first monitoring process, X-ray is the second, then clinical assessment. So, all what we have seen, many people are prescribing ESR in diagnosing or in monitoring the patient. It is not desired, it does not serve you any purpose. Now, treatment of drug sensitive tuberculosis, as we are talking today drug sensitive, treatment of drug sensitive was before 2017 guideline, it was divided into new case and retreatment case. I must take you little history. Last guideline was before it was updated in 2017, it was 2009 when they have clearly prescribed new cases and retreatment cases. New cases were like 4 drugs with 2 or 3 drugs in continuation phase, and then retreatment was 5 drug regimen including streptomycin. That was in 2009, that was in vogue till 2017. And then the standards of TB care in India was there, and they advised that whatever standards of TB care was there, they should be adhered by the government and by the private sector also. And in that again it was this technical operational guideline based on the standard of TB care in India was again new patients and previously treated. But in 2017 this drug sensitive TB guideline was updated by WHO and then by ATS ERS Society in 2016 and 17. And both the guidelines have clearly said now all patients who are drug sensitive, whether new case, whether retreatment case, they will just receive only one regimen, that is 4 drug to begin with, INH, rifampicin, pyrazinamide, ethambutol, and then in a continuation phase in India, because of the high level of INH resistance, we use 3 drug, that is rifampicin, INH and ethambutol. Total duration is 6 months. And this 6 months duration can be extended to another 3 to 6 months depending upon the case scenario, especially in CNS TB, skeletal TB, disseminated TB, and there it can be extended. Even ERS guideline, clinical guideline, they say that Sometimes we do clinically, we increase the duration of treatment instead of 6 to 9 months, especially if there is a large cavity, especially the patient is active smoker, he is a diabetic, being overweight, he is HIV infected, he is a extensive disease. These are the situations where ERS has actually, but WHO has extension only to situation I have just told you earlier, but ERS has little more situation where you can extend, and in clinical practice we sometimes do this. Dose also, you know, you have to see that Government of India has fixed dose in 2019 in 5 weight bands, and even in person who is more than 75 kg, rifampicin goes even up to 900. So, this everyone should remember and should prescribe the doses according to weight. We have guideline for extrapulmonary TB also. What we have seen, when especially I will talk to some of the treatment in special situations like X-ray, tuberculosis and pregnancy. Usually X-ray is avoided in initial 3 months. If it is very necessary, then it should be done with proper seal. And all the drugs, at least INH, rifampicin and ethambutol, they are very safe in pregnancy. And then pyrazinamide, if it is necessary, yes, you may use it. Of course, you have to avoid injectables and ethionamide, although ethionamide is not used in the drug sensitive TB. And so, that is what we do, and we always caution that if you are using rifampicin, then alternative contraception methods should be used. Then nursing mothers are also they should not be discouraged for breastfeeding, and they should continue to take the drug. Diabetes also, you have to manage both the disease. I always say, if TB is associated with diabetes and if you do not manage properly diabetes, same treatment will not work. So, in TB and diabetes, very strictly we say that diabetes has to be maintained, has to be controlled adequately, then the drugs will act in TB. Otherwise, as I have seen, sometimes you have to prolong the treatment. HIV and TB also usually what we see that same regimen and an antiretroviral drug should be started as far as possible. Extrapulmonary TB, in most of the extrapulmonary TB, as I said, the treatment remains the same, and only with few exceptions, that some extrapulmonary sites like brain, like skeletal, like disseminated, there you have to prolong the continuation phase for another 3 to 6 months. Otherwise, treatment remains the same. Another question people do ask, the how you manage tuberculosis, especially when person develops hepatotoxicity. Now, I think this slide will tell you very clearly, you just concentrate, focus on this slide. You know what we say, that if somebody, suppose somebody has SGOT, SGPT, LFT you did, SGOT and SGPT less than 5 times, not too much of symptoms, then you may continue the drugs. But if the SGPT is more than 5 times, even more than 3 times with serum bilirubin raised, and even if patient is highly symptomatic, what you do, you stop all the therapy, except in scenario where TB is very urgent to treat, then you can give hepatosafe drugs. And after the jaundice disappeared, a patient become asymptomatic, what we can reintroduce the drug one by one. And usually the reintroduction sequence according to ATS guideline, they say that first you introduce rifampicin and then isoniazid and finally pyrazinamide if it is possible. But usually in India, but usually the British Thoracic Society, they say no, sequence of events should be isoniazid first, then rifampicin, and I also follow the same regimen. You know, my own way of deciding about the reintroduction of ATT is first we should start streptomycin and ethambutol, they are hepatosafe, levofloxacin, they are hepatosafe, and then reintroduction should be done. First you introduce isoniazid, then you reintroduce rifampicin, and then if it is possible in some of the patients you may reintroduce pyrazinamide. Reintroduction is usually I prefer start with smaller doses and go in 3 to 4 days time in a full dose schedule. That is how, but one thing is to be noted, when you suppose you cannot use rifampicin and pyrazinamide and the regimen becomes ethambutol, INH and rifampicin, then duration should not be 6 months, it should go for 9 months, because you have not been able to use pyrazinamide. And in case of the if you are not using even rifampicin also, like you are using ethambutol, INH, streptomycin, then treatment should be for 1 to 2 years. Creatinine clearance, especially in the creatinine clearance means in some most of the drug I think is very safe. In only thing the drug should be intermittently given. You know, INH and rifampicin, they are safe, but it is the pyrazinamide and ethambutol, their dose is done thrice week. And finally, last 2 minutes I will say what is going to be treatment of TB in future, especially I will be restricted myself to drug susceptible. When I talk about the drug resistant, then I will talk about drug resistance in future. So, future what is going, you know, lot of good news is lot of new drugs are in the pipeline. And you know, before this in 2014 and 15, people have tried to reduce the duration of treatment of drug sensitive tuberculosis to 4 months by using fluoroquinolones. But ultimately all these studies done, Remox trial was very famous, and they say that it is not possible to reduce the treatment of drug sensitive. It was a story of 2014 and 15. Then you know, recently it was published in 2021 with the 4 months treatment of rifampicin regimen. They are replacing rifampicin with rifampicin and with or without moxifloxacin, and they have done that if you use 8 weeks of rifampicin high dose, isoniazid, pyrazinamide and moxifloxacin for 9 weeks and rifampicin, isoniazid and moxi for another 4 weeks. So, this is probably a landmark trial, still the treatment not has been shown. That is giving you some inkling what future. So, future probably we are going to reduce the duration of treatment of drug susceptibility. At present I am very clear, it is 6 months. We wrote an editorial that probably we are moving towards universal drug regimen. Yes, I am sure that in next 5 years probably you will have, with new drugs we will have one regimen which might be used for drug sensitive as well as drug resistant tuberculosis. So, my concluding thought, I come to end of my presentation, and my drug what is important is drug susceptible TB. What you should know that this is the regimen, this is now standard regimen 2 months and 4 months, and then diagnosis should be correct. Before you start the treatment, diagnosis should be correct based on clinical, radiology and laboratory. Can be this treatment can be extended for 3 to 6 months, I have already explained to you, and then compliance of treatment is also very important, and notification is also very important. And yes, you may think of empirically treating the patient. Some of the patients where you suspect that TB is very high and you have excluded other disease, you may think of it even today. So, with this I would like to inform you that I have lot of YouTubes, even this lecture is available on the YouTube. If you wish, you can go on to my YouTube channel, and then we have lot of history taking, X-rays, physical examination. We have lot of books in tuberculosis, manual MDR, XDR and adverse drug reaction, 100 cases. We are coming out with a book on chest X-ray. So, I think with this I must thank you for your patient listening, and if you have any question, I will love to answer those questions. Thank you very much. पूछ कौन पूछे कैसे क्या कर
न्यूट्रिशनल डाइट क्या होनी चाहिए और क्या एमडीआर टीबी ट्रीटेबल है?
Somebody has asked a question, what should be the nutrition? I am very clear in my statement that that nutrition, what I say usually, normal nutrition is enough to treat tuberculosis. Whatever nutrition is required to live, that nutrition is sufficient for management of tuberculosis. But if somebody is deficient, suppose somebody is deficient in some of the issues, then we have to replenish it. Although Government of India is providing 500 rupees per month in all TB patients to get an extra diet. Yes, most of the patients are poor, they are not getting good diet, so that can be done. But ordinarily what I treated tuberculosis in last 40 years, whatever good diet is required to live, that diet is sufficient to manage tuberculosis. Somebody has put a question on MDR TB. Today my talk was not on MDR TB, so I have not touched, but I am very clear MDR TB is also treatable. Next time when you will come on, we will probably my next encounter will be on drug resistant tuberculosis, then we will go on details of MDR TB and XDR TB. But yes, it is a treatable. New drugs are available now.
Where patient can meet you, sir? Patient are asking, where can I meet you?
Well, I work in ERA at this moment, I said, and then I had evening practice here in Lucknow. If one is interested, one can come to my clinic, and my you can note down a number 9161 811 811. That is my appointment number. Anybody can fix an appointment and can see me.
Lactating mothers, is there any effect of tuberculosis drugs on lactating mothers?
No, I said lactating mother can there is hardly any effect. So, lactating mother can take treatment, can feed their children, there is no issue into it.
Sir, one patient is asking that he is taking paradoxin with N-acetylcysteine. Is there any effective role for that particular combination for TB patients?
I think the paradoxin, yes, in certain situation, most of the time we prescribe paradoxin 50 milligram to prevent the neurotoxicity, one thing. And what was the second question? N-acetylcysteine, yes, there is empirical, but yes, many of the doctors are prescribing about it, but at least but the paradoxin is essential in many of the situations.
Paradoxin with other combination or paradoxin separately?
Usually, paradoxin if it is available, if it is not available separately, you can use with other combinations. Because many of the combinations I saw, there are antioxidants and this role is, so there is no harm in taking those things.
And XDR TB role of paradoxin, is there effective role?
Yes, yes, definitely. When I will talk next time about the drug resistant tuberculosis, we are definitely going to talk in detail. And another point, somebody has asked me that about the nursing mothers, what he can take. So, breastfeeding one can do, give the RX after breastfeeding. What one advice you give, if you are breastfeeding your children, then you can do after you have taken the drug. Means drugs are given after the breastfeeding.
So nutritional combination and drug combination is both are very very important for TB patients.
Yes. कहाँ है मेरा फेसबुक इसमें भाई, हैं? क्यों? ये तो नहीं सिस्टम, ये सही नहीं है भैया। इसमें कहाँ आ रहा अभी है ऑन की?
हाँ सर, मैंने ऑन देखा है आपका।
कहाँ आना है?
सेशन देखा होगा। अभी आपका सेशन खत्म हो गया।
अच्छा, ख़त्म कर दिया?
हाँ, वो डिस्कनेक्ट हो गया। जैसे ही आपने बोलना बंद किया, मैं इससे उसको गया और ये पूरा रिकॉर्ड हो गया हमारे पास। इसका हम पूरा बना के
लेकिन ये सिस्टम हमें नहीं, हमको ये सिस्टम यू हैव टू रिवाइज, ये सिस्टम है नहीं सही। जैसे हम लोग ये फेसबुक लाइव पे देखते रहते हैं भाई, सब लोग वहीं सामने सवाल करते हैं, सामने वो हैं, वही तो जूम वाला वो ज़्यादा